Welcome, ladies and gentlemen, to the latest webinar in the series of Pharm-Olam webinars on key clinical research topics. Today's subject matter is evolution of response evaluation in oncology trials. I'm sure all of you know something about response assessments and design of clinical trials in oncology, but these days, due to many changes and new therapies to immuno-oncology, we think it's a good time to reevaluate some of the tools being currently used and looking forward to what's coming in the future. I am Yamin Mo Khan. I am the Executive Vice President for Clinical Development at Pharm-Olam, and I will be the moderator for this session. Our subject expert today is Dr. Dheeraj Abhyankar, who is the Director of Scientific Development at Pharm-Olam. Dr. Abhyankar is a medical oncologist by training. He has over 15 years of experience in clinical research and has over 25 scientific publications to his name. He has over a decade of experience in developing oncology products across all phases of research and has provided strategic guidance to clients on conducting early phase trials and providing medical support as the IMP has moved through the clinical development process. He has experience of working with new chemical entities, biological entities, generics, and biosimilar products. He also has extensive experience in helping clients to build together clinical development plans, as well as doing that himself in many pharma companies. He has also interacted with the FDA, EMEA, MHRA, and other scientific bodies during his experience. So this is a brief agenda of what we will be covering today. We'll start with a brief history and overview of response and how it has evolved over time. Then we'll be looking at the principle of response evolution, including the various versions of RECIST that have been implemented. This will be followed by response evaluation criteria, especially for solid tumors, including looking at some of the limitations for its use in immuno-oncology trials. And then we have a few slides on the future of response evaluation. And then, as Ryan mentioned, we will finish with the Q&A session, and we request that you submit your questions via the WebEx tool. Before we get going into the webinar, a few words about Pharm-Olam. We are a global international CRO that has experience and expertise in conducting global clinical trials. We are over 23 years old right now, have offices in 27 different countries, shown here on the map, and cover 40 countries globally. We are a mid-sized, privately owned CRO, and our aim is always to offer a fast, flexible, and high-quality service. I will now hand over to Dr. Abhyankar to give the rest of the presentation. Dr. Abhyankar.
Hi, everyone. Good morning, good afternoon, good evening, and I know you have joined all across the globe, and I'm very excited to present you about this developments, what is happening into the evaluation of the response of solid tumors, basically, in clinical trials in oncology. So all of us know that the response evaluation is necessary in clinical trials and practice. Response in solid tumors is done mostly radiologically, and I'm going to take you through about the way the history has happened. So there was a time when people used to do it by doing palpating the tumor. So it evolved over the time because everyone wanted to have reliability of the data. The data should be comparable between the two different trials. The drugs should be comparable, and it was necessary from the perspective of regulatory agency to give the marketing approvals. This is basically evolved because there was advances into the radiological technique. Also, in last 10-15 years, there are so many changes happen in the way the oncology drugs are acting. So I'm going to take you through the different way of action of the drugs. And for today's topic, I'm just going to cover about the solid tumors, and I have not tried to cover the lymphomas, or the leukemia response criteria. So if I take you through the brief overview, now essentially this is the slide which talks about whole crux of the presentation. So if you look at it, that the whole response evaluation evolved from 1979 till 2009, and it's still evolving. And I'm going to talk about that. But in the criteria which evolved is in 1980s it was WHO, then in 2000 it was RACIST, then RACIST got evolved into RACIST 1.1 in 2009, and that time there was some technology advancements, and the PERSIST evolved, and at the same time there was an immunological related response criteria evolved. Now, this happened as the technology also simultaneously moved and evolved. So when WHO was predominant, that time X-ray and CT scan was part of the response evaluation. As we moved further and the CT and MRI started getting into the picture, RACIST 1 and RACIST 2 evolved. Then PEG became not really a standard of care, but then PEG started having an influence into decision making. That time the PEG got integrated into RACIST, called as PERSIST, and then immunological drugs, when they started coming in, they changed the way the response are evaluated. So initially it was related to cytotoxic drug, where the reduction of tumor was a primary criteria, where the WHO and RACIST 1 were. And then the targeted therapy came, and here even the stable disease became very important parameter, and then RACIST 1.1 tried to address that. And then when the targeted therapy came, there were some limitations which came with the RACIST, where the PERSIST came, and then with the immunological ones, the immunological related response criteria came. I should tell you this, that there is a still today also RACIST 1.1 is considered to be standard from the regulatory point of view, but I want to talk more beyond regulatory point of view, and then let's see how this progress happened. So apart from the criteria which I just described, there are other criteria which all the different groups are suggesting. So like in the prostate cancer, also there are response criteria for neuro-oncology, immunoneuro-oncology, mesothelioma, ovary, and then there is for hepatocellular carcinoma, and there's a GIST and all other cancers, which I'm going to talk about. So coming back to the topic, so what are the real principles of response evaluation? So response evaluation has to be a quantitative evaluation of measurable lesions. Along with that, it has to be a qualitative evaluation of non-measurable lesions. Before the evaluation has to happen before and as the treatment goes on at the regular intervals. Preferably, same method of investigation should be used because that would make it better standard. Typically, most of the response criteria are having the 4 categories: complete response, partial response, stable disease, progressive disease. Initially, and there is a mandate that if the patient is having a complete response or partial response, those response has to be confirmed before saying that the patient had, or before saying that the patient had complete or partial response. Now let's look at some response criteria. So there was an era which was pre-WHO. I'm talking about an era before 1980s, where Mortel and Hanley evaluated tumor size by palpation. So they had multiple trials they evaluated and multiple patients, and then they tried to blind the oncologists and try to measure them by palpating and looking at the scale. And there they found that there was a high false tumor reduction or high false positive kind of response in 19 to 25% of cases. That was the variability which, because of the two assessors, when they were assessing the tumor response, that much the difference they saw. So they recommended that the true tumor response should be more than 50% only. And then they also said that 25% reduction in product of the diameters as a response. So it has to be measured into 2 dimensions, and that's how it should be measured. And 50% reduction as a significant reduction in size. Not only that those days the oncologists used to measure it like that, but this 50% stayed into the WHO criteria also, because though there was an advancement of the technique, but these numbers stayed back for some time to come. Then, just to standardize it, WHO formed a committee and tried to come out with a criteria so that they can standardize it. That time, CT was available in 1980s, but that it was not prevalently used. And still the tumor measurement was done either by palpation or by X-ray. Some of bidimensional measurement or greatest perpendicular dimensions was used, and that's how the tumor response were evaluated as a complete response, where all the tumors had disappeared for at least 4 weeks. Partial response, 50% or greater reduction from baseline, confirmed at 4 weeks. There was no terminology as a stable disease, but they used to say that there was no change. And there is a progressive disease, which is at least 25% increase in new lesion. There were several limitations, and many different groups like Southwest Oncology Group and other groups had raised their issues because they were not able to find this criteria to be enough valuable to apply into their clinical practice or to synchronize between the trials. So the chief limitations were that the progressive disease, which can occur just by increase into the tumor size, because the WHO was taking it as a bidimensional. So anything which is increasing by 11% would increase it more than 25%. So by bidimensional, if it increase, then it will increase more than 22%, and then that would theoretically become progressive disease. There was no explicit on number of tumor foci to be measured or how small a lesion could be measured. That clarity was not there with the WHO criteria. Then the group of doctors, multiple different tumor boards, they came together and tried to make a consensus and came out with the RECIST criteria 20 years after the WHO criteria came in. And they came out with a guideline which talks about that, and this is just a summary of what RECIST talks about, that up to 10 target lesions can be assessed. Transaxial imaging with CT scan is mandatory. Only some of single longest dimension should be done. So this was a major change from the WHO criteria where the bidimensional was utilized. The minimal size of the lesion has to be 1 centimeter. And there was category for target and non-target lesions. And they categorized response as complete response was disappearance of all tumor for at least 4 weeks. Partial response as 30% decrease, and stable disease and progressive disease where at least there is a 20% increase from nadir of new lesion. Now, when you compare WHO and RECIST, there are 3 major differences which we see. That when we talk about the 20% increase, that is a progressive disease, is seen in 44% increase in the bidimensional dimension. Then less frequent PD using RECIST than with the WHO, and time to progressive disease can be shorter with WHO. So these are the major differences between WHO and RECIST. Limitations in the RECIST, which was raised later on, where there was a difficulty in assessing less than 10 lesions. There was a question that is assessing less than 10 lesions are adequate, because people were saying that why we are looking at 10 lesions. Then there was a major controversy from the regulatory point of view that in phase 2 trials, everyone looks at the response, but in phase 3 trial, it is the overall survival becomes endpoint. And then whether the response correlates with the overall survival, that becomes a big debating point. Then use of new technology like MRI or PET scan, assessment of lymph nodes was not addressed into RECIST. Also, the response confirmation is really needed, and applicability of targeted non-cytotoxic drugs were evolving, and then their RECIST was having limitations. And again, there was one thought which was coming that this whole assessment was kind of anatomical assessment rather than functional assessment. So how true it is? So RECIST tried to address some of the issues. They went through the literature and tried to find out that what could be the rational way of doing it, and came out with the RECIST 1.1 in 2009, where they said that longest dimension for the tumor and short axis for the lymph nodes was evaluated. Minimum measurable lesion should be more than 1 centimeter for CT scan, more than 2 centimeters for chest X-ray, and lymph nodes should be more than 1.5 centimeter. Up to 5 target lesions in 2 organs were allowed, and progressive disease was defined as it was same, but increase should be at least 5 millimeter from the nadir, and non-measurable lesions should have substantial worsening. And the PET scan can be used to reconfirm PD or confirmation of complete response. So a confirmation of partial and complete response were only necessary for non-randomized trials with overall response rate as an endpoint. Now let's look at, so they introduced in 1.1, they introduced new terminology called as non-target lesions. So these are the lesions like bone lesions, leptomeningeal diseases, pleural pericardial effusion, ascites, inflammatory breast disease, lymphangitis, and cystic lesions were considered to be non-target lesions. It's also worth noting that the patient with measurable disease should be included in protocol with response rate, and select largest reproducible measurable lesion to record multiple non-target lesions of same organ as a single item. Lesions with prior local treatment, unless and until PD is documented there, should not be used. Osteolytic lesions where there is a soft tissue component can also be included. Lesions with the split or coalescence on treatment, there was a guideline written for that. An additional requirement of PD was, as I said, that it has to be absolute increase in 5 millimeter. And non-target, there has to be a overall change in the tumor burden as well. So overall, these are the changes which are between RECIST 1 and RECIST 1.1, which I almost summarize everything. So let me move further. Now, as RECIST 1.1 become very standard, I thought that it is a good idea for us even to review that what are the common mistakes I made in 1.1, RECIST 1.1. So there is assessment of non-qualifying lesions. Though this appears to be a very common one, means like how can people miss this? But in my personal observation, and also there is a review article which says that these are the ones where the common mistakes are made, where non-qualifying lesions were utilized, or measurements of the irregular or non-reproducible target lesions were done, or inclusion of bone metastasis happened into the clinical trial, or evaluation of cystic or necrotic tumor changes were used. Also, reappearing of lesions were considered as progressive disease. Baseline or nadir as a reference progressive disease kept on changing, and there was inconsistency in follow-up in the lesion what is already been measured into baseline. Now, so these were the criteria when you use CT scan or MRI. These are essentially the anatomical response criteria, which have limitation that when the cytotoxic drug, where the tumor remains the same, but it's not growing, that time it has its problem. Or we don't know whether the patient may be benefiting, but then since it is a stable disease, anatomical response criteria have a limitation, and also overall survival benefit with the limited anti-tumor size seen in hepatoma treated with the sorafenib has highlighted that the anatomical response criteria may not be that good criteria to go with. With that, when the PET came into the breast cancer treatment evaluation in 1993, and which can detect a smaller than depicted in CT scan, there were two criteria which emerged. One was EORTC and other one was PERSIST, which also came in 2009. And this response was assessed as continuous variable as percentage of SUL peak, which is evaluated by PET scan. So CR was complete disappearance of the tumor, partial response was less than 30%, and 0.8 unit decline in FUL, and progressive disease was more than 30% and 0.8 unit increase in FUL. Now, even the PET scan, so PERSIST is not still a regulatory standard, but then something very unique happened, that when the ipilimumab trial was running, they saw that there are patients, those who develop a stable disease initially, and then there is still increase into tumor mass. Then progressive disease is followed by response or stable disease. And sometimes it takes longer time to really see the response, or discontinuation of therapy need to be confirmed pathologically for progressive disease to be confirmed. Allowance of clinically significant progressive disease is recommended, and durable stable disease may represent anti-tumor activity. At the time of ipilimumab, there was one more mAb which was developed, and that whole drug could not get a regulatory approval because they insisted in following RECIST criteria. And when the ipilimumab, when they had this observation to phase 2, they changed it to be a criteria for progression-free survival, and that's where the ipilimumab got the approval. But simultaneously, since so many drugs were developing in immuno-oncology, that's where there was a requirement for the new criteria, though it is not still been approved by or accepted by the regulatory agency, but it is very accepted and then practiced into clinical practice and also in the clinical trials. So this is called as immune-related response criteria, where the assessment as a continuous variable, where the lesion at baseline, or even if the new lesion comes after baseline, that is not considered to be a progressive disease. Only measurable lesions and bidimensional measurements again came up. So RECIST has taken an approach of unidimensional. Again, WHO had a bidimensional, and IRRC again brought in the unidimensional measurement. Some of IRRC is still using a bidimensional measure, so which used to be used in the WHO criteria. Some of the perpendicular diameter at the baseline is added to a new lesion to calculate the total tumor burden. So just because there is a new lesion doesn't mean that it is a progressive disease, but that would be added on to the sum of the diameters, and then that would be evaluated as whether there is a tumor burden has increased or not. That's how it would be evaluated. There were new terminologies which were coined, which are IRCR, IRPR, IRSD, IRPD, but the response criteria categories were same as WHO. And as I already said, that the new lesion alone is not progressive disease if it is not adding to the 25% to the tumor burden, and new lesion but overall tumor burden decrease. even if there is a new lesion, but there is overall tumor burden decrease, still the criteria would come as PR or stable disease will come into picture. So we have seen that these were the standard way where the criteria were evolved. But simultaneously there were some groups, those who wanted to have a specific criteria for the specific cancer. There were criteria for glioma, there was a criteria for neurological metastasis or bone metastasis. There is a criteria for CHOI, which is for GIST tumor, or there are multiple criteria for hepatocellular carcinoma, prostate cancer, mesothelioma, and ovary. So let's look at the Reno criteria for high-grade gliomas. So McDonald in 1990 evolved a response criteria for high-grade gliomas, and based on CT scan, like WHO, here they added a criteria that corticosteroid use. So increase in corticosteroid use was not considered to be a response, and change in neurological status was also not considered to be a criteria. Pseudoprogression was seen and the compelling reason for making a different change, different criteria for evaluating gliomas was because they have seen that the progression which was observed, which was considered to be a progression by the standard scale, in the temozolomide radiotherapy trial, it was only pseudoprogression in 20% of the cases. And progressive disease was defined after three months treatment, unless new lesion is confirmed by the pathological biopsy, and RANO permits progressive disease to continue treatment pending follow-up imaging. Now, I'm not going into the detail of the RANO criteria, but RANO criteria initially was evolved for gliomas, then it went to the brain metastasis, and then with the advent of the immunological drug, again there were certain criteria which came into picture, which is where there are two different criteria, which is iRANO, and which is less than 6 months of treatment, and iRANO of more than 6 months of treatment. And the differences, key differences in them are highlighted here, that if there is and if you go from below up, so does a new lesion define a progressive disease? In RANO, it is yes. If the immunological treatment is given, then it is yes, new lesion. But if further immunotherapy is allowed, so if the treatment is given less than 6 months, then still, even if there is a new lesion has come, the treatment has to be continuous for at least 3 months. That is the minimum time to confirm progressive disease. And is repeat scan required to confirm PD without significant change in the clinical? If treatment is given less than 6 months, then it is allowed. So it's very interesting that not only what kind of therapy is given, but even the duration of therapy started having an impact into the way we define the criteria or the way we evaluate patients. Similarly, since all of us know that the bone metastasis is very difficult to evaluate by CT scan or by MRI, so there is an NDA criteria for bone metastasis was proposed, where initially the bone metastases were non-measurable in WHO and RECIST, but Hamoka in 2004 he proposed using X-ray, CT scan, MRI, skeletal scintigraphy, and other supportive technologies to really quantify bone metastasis and use that criteria for defining the response what is seen with bone metastasis. Recommended to follow up imaging every 2 to 6 months, and complete response is that when there is a complete fill-in or sclerosis of lytic lesion or normalization of osteoblastic lesion. PR is seen is considered when the sclerotic region is seen along the lytic lesion, or sclerosis of the previously undetected lesion, or partial fill-in or sclerosis of lytic lesion, or regression of measurable lesion, or there is a decrease in blastic lesion. Every lesion need not regress, but no lesion should have progressed. That was the criteria. So this is again the change that where it has changed, and then they kept the same criteria. What is used? What measurements are used for WHO criteria? Now let's look at the CHOI criteria for gastrointestinal stromal tumor. So RACIST 1 significantly underestimated initial tumor response to imatinib in GIST, and significant changes in tumor density, enhancing anti-tumor nodules and tumor vessels was noted. CHOI criteria use a combination of the values of tumor size and tumor density on CT scan. Complete response was disappearance of all lesions with no new lesions, and partial response was decrease in size of 10% or decrease in tumor density of 15% on CT scan. No lesion for stable disease, and progressive disease when there is an increase in tumor size of 10% or new lesion or new intratumoral nodules. In such tumors, when the contrast is performed, it is the timing of the CT scan also determines the way the response is taken, and then the details about it was also provided in this criteria. Now, these rules for definition of lesion, measurement rules, calculation rules, and response determination rules were not very clearly given in CHOI criteria, and all this criteria is also used for metastatic renal cell carcinoma, high-grade soft tissue sarcomas, solitary fibrous tumors, and hepatocellular carcinomas. Now, as I said earlier, that hepatocellular carcinoma there was a trial on sorafenib, and it was seen that RACIST criteria was not doing justice in the way the hepatocellular carcinoma response and also overall survival was correlating, and that's where the different organizations proposed different criteria to measure. So first criteria came from European Association of Study of Liver. The other one came which is called as modified RACIST, and then one more criteria came which was called response evaluation criteria in cancer of liver, which was proposed by the Japanese group. So tumors are measured in 2 dimensions, and the dense accumulation of the lipidol is regarded as necrosis, because if you give the contrast and if it is there, if it cannot go into some part of the tumor, that means that tumor is necrosis, and that should not be considered as a tumor for the tumor measurement. And first time there was efforts made to look at the tumor markers like alpha-fetoprotein, AFP, L3, and DCP were added into the criteria for evaluating the response. There is a separate criteria which has been proposed by for prostate cancer called as PCWG2 criteria. Now, prostate cancer has a very unique mechanism, unique disease profile, that in spite of giving the therapy, there is a flare-up into what happens into the bone. So bone scan can show a flare-up of disease when the soft tissues and other part is decreasing. So this is a unique property with the prostate, unique characteristic of the prostate cancer, and this group thought that this needs to be addressed. So and also PSA is been into the clinical practice for so long, so they wanted to utilize PSA into the response criteria. And there is again few drugs which have got approved into the prostate cancer were related to the skeletal related events rather than overall survival or response rate. So these 3-4 criteria the prostate cancer working group wanted to incorporate into it, and they suggested this criteria where they said that soft tissue disease in nodes and or viscera it should follow the way the RECIST 1.1 criteria is, but PSA progression as an increase of more than 25% or increase of more than 2 nanogram per ml from the nadir should be considered for progression. PSA decline to be reconfirmed by 3 or more weeks later just to confirm it. PSA progression alone is not an indication to stop treatment, and bone scan progression as either 2 new lesions noted on the first on the treatment scan followed by 2 additional lesions on the next scan. So one has to wait for the next scan to happen, and there has to be 2 more lesions has to come for the patient to be called as progressive disease, or 2 new lesions on any scan after the first on treatment scan that is confirmed on the subsequent scan would be a progressive disease for prostate cancer. Now, all of us know that the mesothelioma present where there is a cancerous growth on the pleura of the pleura, and it is always, it's not a tumor kind of thing, and it demonstrates a non-spherical growth pattern, and that's why it becomes very difficult to measure it by conventional CT scan. So it's difficult to document tumor response by RECIST. So new functional imaging techniques such as PET or DCE MRI is being allowed to be evaluate mesothelioma. For ovarian cancer, gynecologic cancer intergroup develop a criteria where the progressive disease is on the basis of RECIST criteria or also on the basis of CA125 criteria. That is that the doubling in CA125 from the upper limit of normal reliably predicts objective progression. And when this data was evaluated, CA125 was brought into a response evaluation criteria. Now, this is my thought on regards to where this whole criteria is going to evolve further. There is a big debate in regards to, typically in oncology trials, phase 2 trials where these criteria are prominently used are where the response rate is evaluated. And for the phase 3 trial, it is always the overall survival is required by the regulatory agency to give the marketing approval for that drug. Now, then there are enough attempts been made to show that the response rate correlates with the survival rate. Sometimes it correlates, sometimes it doesn't correlate. So there is a continuous debate going on that whether the response per se really have an impact on the overall survival. So one of the criteria which was still evolving is that one should keep on doing the response even, let's say, every 2 cycles, and then develop a graph. And the predictability of that graph or that curve, which would be, that slope which would be statistically evaluated, that should predict the overall survival. And if we know that what would be whether it is someone who is stable for 4 or 5 cycles can remain stable for 4 or 5 cycles more, and then that would have an impact as far as the survival is concerned. Or someone who is showing a complete or partial response would have a response. So there is a thought process towards the continuous evaluation, taking all those data points and developing a statistical tool to predict the overall survival is something which everyone is trying to look at. All of us know that this is the era of individualized medicine, at least cancer is concerned, where now every cancer, like breast cancer or prostate cancer, or for that matter, sarcomas, everyone is saying that though we categorize it pathologically to be this cancer, but looking at the molecular markers on it, that may not be the same cancer. And that's why the selection, what cancer you are looking at, how is what is real benefit to the patient, how do you target the molecular mechanisms, and how do you evolve a criteria which fits and gives you a correct prediction about the overall survival. There is a thought process which is going on in that direction, and the tumor response criteria should be based on the treatment and the type of tumor, and validation of the functional biomarkers like PET scan to prove correlation of overall survival. As I described that, now everyone is saying that the PET could be more sensitive to predict the overall survival than response rate alone. So there are so many things are happening. So though if you look at from 1980s till we are into 2017, the response evolved and it is continuously evolving, and there are now multiple responses which are getting practice into clinical practice and clinical trial. But still we know that it has not gone to a level where convincingly it can translate into a direct benefit to the patient. So I still think that this whole topic of response calculation is evolving, and it will evolve in the near future till we get those parameters on which we can conclusively say that we reached there. So here I stop my talk, and I would be happy to take some questions.
Hi, thank you, Dr. Abhyankar. I want to say I understood everything you said, but unfortunately my expertise in oncology trial isn't so good. So the most popular question we have to date is whether the presentation material will be made available. So yes, all attendees, all delegates will receive an email with directions to access to the presentations, including the audio recording. But if you have any other questions, please use the dialog box on the right-hand side in the WebEx panel to ask any questions. So some of the questions we have already, Dr. Abhyankar, one is, what is the difference between response and efficacy?
Okay. So response is objective way of looking at it, and this is my opinion. Response would be objective. Efficacy could be subjective in a way that someone could be saying that quality of life-wise, this drug is efficacious, or it could be that the patient is just halted the progression-free survival, or it is a disease-free survival. Not necessarily it is directly translating into benefit. But response as such is very objective way of looking at it, where there is a percentage put in there, where we say that this is the number of, this is the percentage, this is how it is. It can go from one criteria to another criteria. That is the way I will call it as a response. Efficacy could be whether a drug is efficacious in just targeting or attaching to the target or not. Whether that is translating into the response or not, we don't know. That would be my thoughts about it.
Great. Thank you very much. I think you may have at least partly answered the next question too, which was, could you please provide examples for qualitative and quantitative evaluation?
Yeah. So qualitative is basically where there is a target lesion and we directly do a radiological evaluation and find out that what is the response. Now, qualitative response is if you look at the non-target lesion in RECIST 1.1, where there is, let's say, pleural effusion or ascites. Now, you know that the ascites is decreasing or pleural effusion is decreasing, but you won't be able to quantify it, that how much is the decrease, because it is having the impact, it is because of so many other factors rather than only disease.
Thank you. Next one is which blood biomarkers are used for defining progression of disease in disease-specific response evaluation?
So, as I said, that PSA, CA125, and then alpha-fetoprotein and other markers were utilized for as a blood biomarkers, which can be utilized, but they are not still been accepted by a regulatory agency as a biomarker for evaluation of response, but they are still practiced.
Okay. Next one. What is the normal length of lymph node according to RECIST 1.1 criteria?
So RECIST 1.1 has said that the normal lymph node is 1 centimeter, and anything above 1 centimeter is considered to be is related to cancer. But if the lymph node decreases below 1 centimeter, it is not considered to be elimination of disease. Every time every time the least count which is considered for lymph node is 0.5 centimeter. When the lymph node disappears. So, okay, coming back to your question, 1 centimeter is the criteria for RECIST 1.1.
Wonderful. Well, thank you very much for an excellent presentation today. I hope everyone in the audience found the presentation useful. If you do require any further information or further insight, please go ahead and visit our website, which is on the PowerPoint slide at the moment, www.pharm-olam.com. You can contact us at info@pharm-olam.com, and we would be happy to follow up with any further information. Please continue with us as we announce more further webinars on different topics of clinical research. And until then, we wish you all the best. Goodbye. Thank you very much.